Merci pour votre présence cet après-midi. C'est notre dernier symposium. On a la chance aujourd'hui d'avoir, cette conférence-là va être une co-conférence. Ça va être Marianne Olivier d'Avignon, qui est professeure, je pense que tu as changé de faculté, j'allais dire, en travail social à l'Université Laval. Puis on a Vincent Couture, qui est professeur également à l'Université Laval à la faculté des sciences infirmières. Donc, sans plus tarder, je vais leur laisser la parole. Ils vont nous entretenir de l'expérience parentale entourant l'annonce d'un diagnostic anténatal avec pronostic réservé, regard sur le processus informationnel et décisionnel vécu et ses conséquences. Alors, sans plus tarder, je leur cède la parole.
Bonjour tout le monde. Donc, ça nous fait plaisir de vous présenter les résultats d'un projet qui a été vraiment très, très intéressant. Oui, le bouton, comme Catherine dit, est fatigué. Hein? OK. Aucun conflit d'intérêt, aucune affiliation financière ou autre avec un organisme à but lucratif ou non lucratif. Les objectifs qu'on vous propose, c'est qu'à la fin de cette présentation, connaître les conséquences vécues par les parents lors de l'annonce d'un diagnostic anténatal avec pronostic réservé, identifier les avantages des soins palliatifs périnataux comme option d'accompagnement pour ces familles, relever des enjeux éthiques dans certaines pratiques d'annonce de diagnostic anténatal avec pronostic réservé et nommer des recommandations qui peuvent permettre d'accompagner le processus décisionnel de ces familles. Au niveau du référentiel CanMed, vous voyez certaines compétences qu'on a identifiées. Donc, ce projet-là, c'est un projet qu'on a appelé le projet Pensée, donc un projet qui s'intéresse au processus informationnel et décisionnel en contexte de diagnostic anténatal à pronostic réservé, avec la petite fleur Pensée, mais aussi Pensée parce que dans un contexte comme ça, il y a beaucoup de pensées qui habitent le couple de parents. C'est un projet qu'on a fait en collaboration avec Diane Tapp, Véronique Roberge, mais aussi Alexis Mercier, Sophie Roy comme auxiliaire de recherche et Lydia Lamontagne aussi. C'est un projet qui a été financé par la chaire de recherche en soins palliatifs de l'Université Laval ainsi que l'équipe de recherche de la maison Michel Sarrazin en oncologie psychosociale et soins palliatifs. Voilà. Donc, le diagnostic anténatal avec pronostic réservé, c'est une situation qui touche beaucoup de familles et en raison notamment des avancées technologiques dans les procédures diagnostiques anténatales. Donc, des processus diagnostiques se sont raffinés qui fait en sorte qu'on est capable d'identifier de façon plus précise des anomalies congénitales graves qui peuvent menacer la vie de l'enfant à naître. Donc, de plus en plus de familles peuvent être confrontées à ces diagnostics-là avec un pronostic réservé. C'est un diagnostic qui est entendu pour le couple de parents, qui amène véritablement un choc parce que l'enfant n'est pas né encore. On se prépare à l'accueillir dans la joie de la maternité et de la paternité prochaine et on se prépare en même temps à dire au revoir, à décider si on va mettre un terme à la grossesse et donc à préparer un deuil. Donc, c'est vraiment deux émotions, là, deux grands contextes là, qui s'opposent grandement. Donc, les parents sont mal préparés parce que ça arrive dans un contexte qui est habituellement très heureux d'attendre d'un enfant à naître. C'est un processus dans lequel les parents vont être amenés à vivre différentes phases. Donc, on reconnaît dans la littérature de la détresse pour les parents à l'annonce du diagnostic à pronostic réservé. Donc, les parents, souvent, vont apprendre que l'enfant à naître est atteint d'une malformation grave dans le 2e trimestre. Après des premiers tests, il va y avoir des tests confirmatoires. Donc, ça amène beaucoup, beaucoup de détresse. Suit un temps de réflexion dans lequel les parents doivent prendre une décision. S'ensuit une intervention, soit une intervention de la grossesse ou une décision de la continuité de la grossesse, puis une post-intervention. Il y a de la détresse dans tout ce processus-là qui est bien documenté. Et les soignants aussi sont très importants dans le processus. Ce projet-là émane d'une discussion avec des cliniciens qui nous verbalisaient très grand niveau d'incertitude. Donc, on donne de l'information. Ensuite, les parents ont appris.
They will have to now take a decision where they will have the first situation where they will have to make the decision and the application of this decision. And so the process we have is trying to document the whole experiment that the parents will have. And so it's a pool of data that is unprobable, and it was made in city of Quebec. And so there was two phases in this research. There was it was during the period of the pandemic, and so we went to talk about the post-traumatic stress that they might have and the decisional regret that they might have. Yeah. There's a small echo of my voice, and so here are the interviews we made towards 13 people. There are 12 people and 12 women and 1 man, and there has also been interview made after the announcement, and so these are the usual period of announcement. It's usually 4 weeks, and it has been told from 18 to 35 weeks, and these are the numbers we have. And so the people that made the announcement, we identified that there was 5 story in 5 stories. There was the gynecologist that let them know. 2, there was a cardiological. So what we have here is who helped you in this decision that you had to make, because people receive the information and then they have a time. We gave them another appointment to tell us the decision that they will make. What would you do once you hear that your children has malformation during the pregnancy? And so the parents leave, and then they have to make a decision. And so we ask them who supported them during, and usually it's the husband or wife and other members of the family, and 2 people sometimes are the nurses, sometimes it's the social worker, the family members, and the husband that can come and help. And some people receive no help in making the decision. And so some people decided to proceed with the pregnancy, where they wanted to go with a palliative process. So some people said no, and 4 people said yes, and 9 people said no. And so 12 people on 13 decided to not proceed with the medical procedure. And so we wanted to know what were the wellness, the physical and psychological wellness of the mother, and 11 people said yes and 2 people said no. What was the wellness of the psychological and physical wellness of the father? 2 people said no and 11 people said yes. And what were the wellness of the prenatal children? And 4 people said yes and 9 people said no. But the women participant, they all said how they felt, how worried they were for their husband or their partners, and how the partners had to go back to work too fast, and so they were worried for their partners. So we documented the distress elements of the announcement. A lot of the participants said that they received from receiving this announcement of the problem of their onboard child. That will we use many words to describe that. From receiving this announcement in the car or in a hallway, it has been indicated that it's a favorable place to receive this announcement, and so the people that were satisfied of the announcement were the people that were in a nice room, in a room with privacy, with a box of paper to blow their nose if they have the problem. And so about the distress information, they said that the doctor sometimes announced it as if it's like the only choice, only way they have is to prevent this pregnancy from existing. And so they don't like the pressure that they received. They wanted to know the other options that they had, and they wanted to have a to be linked with other parents that had to be put in that same situation. And so they felt like they didn't have enough information for the condition and the position that they were in. It's also almost as if there's only one choice. But the things that they liked were when the doctors presented many options to them where they could choose where to go, what could happen if they keep the baby or don't keep the baby. And so with more information, with more material, they're able to make a better decision, and that's how they felt. And these are the positive points that they brought up. There were some participants that said that when they had to share the decision, they said they seemed that the doctors seemed relieved of the decision, but it seemed as if it did not help. Actually, they didn't want that from the doctor, and so the person that's at home that has only 2 days, it feels like they don't have enough time. They tell us that the decision has to be made before the 24th week, and so sometimes they only have 2 days, sorry, to make this decision, without 2 days to make the decision without any help, any more information, and or if they feel distressed, they have nobody to talk to. They felt isolated during that period. It's clearly it's a pressured decision. Some elements of satisfaction they felt that is when they felt a respect, where when they announced it and that the execution of the intervention was made clearly and cleanly and fast, without wasting time. They liked that about the experience. So about the transition, when the couple had to deal with the moment of distress, they sometimes did not feel ready to see that the baby is still alive for a few minutes during the procedure, and so they never talked about that. And sometimes that was not a nice experience, and they wanted to know that beforehand of making that decision or beforehand of the procedure. And so when you leave from the hospital after experiencing people experiencing hearing the baby, the heart of the baby beat, they really felt trouble from that experience. And so the negative points that they had, the whole time that they had, the time where you have to stay on in the hospital and being treated by the nurses, they said that they liked that experience, but that was a whole nother universe from making the decision, and it was a whole nother team that helped them with that. So with the questions that we asked the participants of this research, we saw that there was a lot of of ethical questions, and with the interviews, we saw that there were themes that came back often, that were linked to specific steps of the way. And so we saw two big families, and so the big ethical families we saw were autonomy principle. The we have we have subjects about challenges about autonomy principle, and then we have the wellness principle, where we had to deal with the quality of life of the children, and or of letting the pregnancy go all the way to the end, and having the chance to meet the kid that would come out of there. And so in link with there was a lot of elements that would prevent this decision from being clear and concise. And so how Marianne said it, they said that there was a lack of time to make the decision. So let's say you're doing the 23rd week, and then they tell you you have to make it as fast as possible. The parents, the abortion had to be talked about during the ethic committee, and so when the family made the decision, and so time was really a important factor during that experience. And so these announcement with these type of announcement creates a shock that is really heavy, that removes the capacity to make the decision that they have to make. And we have to say also that during the interviews that to have time to get the information that you want, to see other points of view of people that had the same experience, and getting more information to make a better choice. That's what they wanted. Another element that they talked about is that was more in report with the nature of the information that was gave to the people linked to that problem. And so they had a lot of information about the abortion of the baby for the wellness of the kid, and so that's what they were informed about, but not the other subjects. And so leading the pregnancy to term was really talked about. And so talking about palliative care before of unborn child is something that's rarely talked about. Another thing that was not helping into the decision making of this announcement was there was a lot of participants that said that they felt that the doctors really liked more the abortion decision of where they tried to insist to make that decision, where they're not presenting any other options. They're all saying, please make the abortion. And so by lack of information, that's what people usually choose. And so the people feel pushed towards one direction more than the other one, and they felt pressed to make that decision. And then they felt as if they were judged if they had any ideas or way they wanted to see the pregnancy come to term. And so another element that did not help with the decision making of the situation was that when there wasn't common accord on how to make this decision, in the last one, there was one participant that said that the way other people looked at this decision that they were about to make of the following or not of this pregnancy, she felt like she would have been judged. And so what I present to you was more about the being having the knowledge enough to make a proper decision, but for the quality of life or wellness of life, the one of the things. So so the participant mentioned a lot that the the heaviness of the intervention, the idea that if we put if we have the kid brought to life, there would be a lot of surgery and things that would ruin the quality of life to the child, and so they didn't want to afflict this type of pain to the children, and so they saw a useless care that they would have to give to the child, and to prolong your life that would be stopped sooner or later. So they that's one of the points that they mentioned. And so the other one would be of the handicap and the suffering that that the handicap would bring of the child that would be born, and it would be it was really saw as a lower quality of life to have to live a life with this handicap. And so in a space where there's a low life expectancy, people usually are not, or that's one of the points that they keep in mind while making the decision. And so the last point that is quite important is the uncertainty of the prognostic. So since we don't really know how long the child will live, or the complexity or how heavy the illness will be, we only have an estimation. So this uncertainty was really hard to live with. A small word about the limits we had during this study is that there was some biases during in the pool of the people we had, and so there were people that were in social groups, support groups of onboard child decisions, and there was a small amount of people that were in that type of field. And so there were people that the pool of people we took were from one region only, so that's a bias we had. And also we used the quantitative measure to scale. There was there were there were no people where we could have can measured the regret that they have in a quantitative way. And so it was really hard for the people emotively, but it was hard to bring that data into paper, and so we were not able to scale it properly, and because of the tool we decided to use. And so and to push further, it's as if it's like a defense mechanism to not go in a decision regret mode. And so it can bring forth a lot of mental consequences. And so we couldn't see any regrets or regrets about the decision, but there were a lot of biases that skewed the result we had. So a portrait of the decisions and the trajectory of the decision. So there were a lot of people that were in emotional shock. They receive information about the health state of the onboard child, where they are usually joyful about the baby coming in, and so this negative emotion with the positive emotion creates an emotional shock, and so it creates a lot of uncertainty because because they since they don't know how bad it will be until we see the children come out. It brings a lot of uncertainty, but there's still a decision to be made before even seeing the child. And so there's an emotional shock where the couple still has to make a cognitive decision that has to be rational in temporal constraint. And so it's really hard to come to a decision. And so we really feel isolated in this period. We don't have a professional to contact when we have specific questions. We don't have people that have lived this situation before that could bring any type of support. There's a social stigma about it, about the maternity or paternity, where usually it's supposed to be a super joyful period of life, full of joy. But no, in this context that we have to take a decision, we make an interruption or we continue with the child or the pregnancy. So to return to the result, the ethical result, like I mentioned, there's a two zone of tension. Anything that was about the clear and concise information and the wish to know this child. And so about the clear and concise information, what seems to interfere and ruin this experience is that ruins this agreement. There's the biggest one that was the time pressure that they had, and also the biases of the medical workers that usually pushes the parents to an option in particular, which is usually to remove the child. But even though of all these lacks, the parents usually take a rational decision that they were okay with. And what seems to have brought them to make this decision in this point of view is the low quality of life that the child would have if they would keep going forth with this pregnancy. And that's what seemed to reassure them in the interviews that we made, and that's what seemed to bring them peace for this medical intervention that they chose. And so the way that it was said, and it says that the weight, the suffering, and the fact that the child will be born with pain or an handicap, and the uncertainty of how long this onboard child will be able to live. What's interesting, which we're in the Palliative Care Congress, which was our first hypothesis that we talked about. If we look at the results, from a palliative care of unborn child, we saw that the palliative care was never presented as an option properly how it should have probably been presented, and so we feel like there's a lack in this domain. So for not proposing all the options that are possible, we see a bias in that sense, and and also if we analyze all the reflection that we have with the quality of life, this idea of quality of life was interpreted from an angle of the care to alleviate the pain, were part of the information that were transmitted to the couple, and it was not presented enough. So if we talked about more about the palliative care for the unborn child, if it was properly presented, it could have helped them to make a better decision. Because we know that the palliative care of the unborn child is there to support the emotional and physical experience of the unborn child. And so here appears, and if this option was presented in all its all its aspects, maybe the results we had would have been different. Maybe the quality of life would have been judged or seen from another point of view, and not only the negative part of the surgery and medication that the child would need. So the palliative care of the unborn child is a way of offering a care to the unborn child, to the people that have a limited life expectancy, or children with a life expectancy, but it's here to help the parents to make the decision and give them the tools to make the decision. Our reflection is that if from the beginning of the announcement we go in a space where we propose them the palliative care of an unborn child, and that there's a support for the family, we in the same way make sure that there's a better support and a better informational support offered to the family and the couple that has to make the decision from the beginning. And so the palliative care of the unborn child is an approach that would help them be more tooled to make decision, and so it would help them make a decision. And so by giving them more tools to make the decision, it would be very important. It would bring more neutrality. They're usually in a emotional shock state, in a state of emotional shock, and there's a lack of time, and so the tools to help them make decision would help them guide them to make that decision and help them negate the effects of the emotional shock that they have, and it would assure emotional support for the family. And so that's it.
Thank you. No, there will not be time for any questions. I'm sorry. No, there they are. The next speakers will be Gabrielle Fortin, professor at the Université Laval in criminology, and her student Elisabeth Derome, who will be there with us, who is doing a PhD in a conference to be parent of a minor child living with cancer, and to know more about these young adults. Thank you, Francois. I'm already stressed with the little button which seemed to be daunting. Francois spoke of the experience of young adults and of sick children, but we will focus on the life of young parents and of those close and near to them. And kudos to the brave ones who decided to attend until the very end. And we're delighted to present this project to you. It is very dear to us. It's connected with our social work endeavor, And I'm also a social worker to the daycare in palliative care for children, in which for over a year and a half we've dedicated a whole day for young adults with advanced cancer. They have specific needs, live a lot of stress, and to leading this project has moved us. So we want to establish connections with what we found in literature and what is being shared. What we are being shared by young adults. There's two of us. So Isabelle is coordinating this project funded by the CNSR, but also José Chénard, who is a co-searcher in this project. As for conflicts of interest, we have none to report, save that the project is funded by the CRSH. So our learning objectives is to present the highlights of the psychosocial needs of young parents who are struck with advanced cancer, and to validate or increase your knowledge of their specific needs, and to be sensitized to those around them are also experiencing. And I will now show you the setting. Who are the parents and the young parents with advanced cancer? And then we are introducing to you the recension of what came out of the several documents we have compulsed, and there are also some elements of discussion, and to present to you the specifications of our research project. Now, when we speak of young adults who suffer from cancer, that's difficult because according to statistics, people will speak of the 15 to 29, which could be lumped into the category of adolescents, while other statistics will speak the 18 to 29, another 18 to 39, and studies will include the whole of the active phase of life, so from 18 to 49. That makes things difficult because the needs of someone in his 20s are not exactly those of someone in his 40s. So we had to find what are the specific needs. And let's begin with the common needs, and then we will hone it to find the specific needs. Now, to be pitted against cancer early in life, there is a heightened distress, given also the life choices one has to make at that phase in life. For instance, studies, forming a family. So the outbreak of cancer will jeopardize all of this, and also the difficulty to define their identity. When you're 25 years, it's perhaps more difficult to say, what have I done in my life? Who am I? How can I? Oh, it's just also an alteration of your self-image and of the treatments and problems of self-esteem, of intimacy, social isolation, because as a young adult, having a condition is marginal. And there's a triple marginalization that will apply here, which I will address at the next slide. There's also the questioning of the possibility of founding a family, and the financial difficulties, which are also important for given the new financial independence, which is age connected, and the access to a well-paid job. So these factors are common to young adults. Where things get more difficult is also to live with the stress associated to the factor and the triple marginalization for young parents connected to a lot of isolation. The first step is has to do, like these past 15 years, we've acknowledged the needs of young adults, but most of them are headed to um, to a cure. But for those who are in terminal case, the services are not adapted to their needs. Another isolating factor has to do with the close family. Uh, the young adults are following treatments which are curative and palliative, but for the extended family, there is a possibility of a cure or a recovery, and it's difficult for the young adults to speak of their condition and how afraid they are of the outcome. But they also want to protect their entourage, so will avoid speaking of the family or of planning anything because they feel death is around the corner. So this is the second isolating corner. And then the palliative care units usually cater to an older demographics. And when you go into palliative care, I mean, these people can can reassess their life, but it can be daunting for a young adult that there will be a comparison between the elderly saying, I wouldn't want to be in your place because I've lived a lot of things. So when a young adult hears this, it doesn't help. Then there's a generational aspect. It is felt among young patients to be performative as a patient or as a parent. The generational aspect is present. I mean, the identity, the notion of gender, and the performance anxiety, which is observable among young adults, but when one is in a group where people in palliative care are older than oneself, so this is the context. So now we wanted to see what happens when we are a young parent with cancer. So that's why I will let Isabelle tell you about the recensions. But before, or review, but before that, I will present to you the methodology from May to November 2021. We followed the TRICO in this colleague's approach. The guiding question here, what are the psychosocial needs of young parents with cancer, with minor children? So we've asked diverse specialists and other publications. We've also consulted recent bibliographies on the topic. We've combined keywords like psychosocial needs, young parents, advanced cancer, minor children, and the conceptual plan was enhanced further to a conversation with librarian from Laval University, and those are the criteria of inclusion and of exclusion for the articles. We included articles such as represent the perspective of a young parent, and the parent had to suffer from cancer and have a child younger than 21 years. We've also reviewed peer-reviewed articles, and the articles between 2006 and 2021. Among the excluded articles were those who presented the perspective of a health professional dealing about the situation. This was excluded, as well as articles where the theme was addressed, but within a curative perspective, also narratives, newspaper articles. So there was a first triage effected by 2 assessors following the reading of the titles and the articles, and those selected were put in a software. A second selection was performed after full reading of the selected articles, and there was a third assessment went to discuss about the inclusion or exclusion of the remaining articles. So this shows the 25 articles that have been kept. 80% come from the United States, and the others come from Australia, Canada, Italy, Norway. And among them, 56% of the studies are qualitative, 28% are quantitative, and 16 are mixed. And most of the articles, 76%, were published between 2015 and 2021. The results could be regrouped under 2 heads. That is the emotional experience of the passions. If we stop at the emotional experience, they highlight a sense of guilt which is generated by a lessening of the capabilities of the young parents to perform their chores. And it's difficult to delegate because scientific writings stress the importance to maintain routine for children. But the more the cancer develops, the harder it is for parents to maintain this routine. Guilt coming from the choices. The rest of the remaining energy will be spent with children to prepare breakfast and go outside or play with the children. But by that time, but then you cannot do household chores, which will be heaped upon only on the other spouse. Also, there's also a feeling of losing the connection with their children as the as the disease develops. So they become more passive rather than engaged. There's also a stress for performance, which is being thwarted, and the need. I mean, with also the phenomenon of a good patient, which is fed by the young parent who wants to survive and to live as long as possible, regardless of the cost. And the caregivers also will opt for aggressive treatment for younger patients. So there is a lot of that is left unsaid about that. But it creates performance anxiety. Then the documentation, the literature says that there is a will to live to maximize the remaining time with the children. This has an impact on decisions pertaining to treatment. Young parents feel they have no choice but to opt for more aggressive treatments to maximize the possibilities of survival, which brings them to clinical trials, or a lot of they want to remain physically close to their family. There's a feeling of inauthenticity that is to generate a process that should be natural. What we mean, what the publication literature says is that these young parents have the feeling that their interactions with their children will create memories for their children. They want to create a perfect recollections, the happiest possible recollections for their children. So the needs could be divided in 3 categories. Those that stem from the formal network, from the informal network, and the financial and material needs. Well, there would be a need, the first, for a longer social support, a need for education and support to improve communication. So when do we speak of the disease to the children? What words do we use to speak of it? There's also a need to accompany in the legal procedures, especially for families with single parents. As also, there's a need for a locale where young parents can confide and share without fear of taboo, and to take some time for them by participating in self-help groups in order to feel better understood. Young parents would also express organizational needs like, for instance, they take care of children for most of the time. They seldom ask this type of support, and they want to remain active towards their children. Also, a need for support and to communicate with other systems, such as schools, daycare centers, like when the school team is informed and there is a regular communication about the disease, it has a reassuring effect on the young parents. Another need towards their own parents, they deplore a lack of service for them and an absence of a spousal approach which would affect a mutual understanding of all the systems. Finally, the financial and material needs. There are worries for their children due to the loss of revenue for the ailing parent, and also to the expenses incurred associated with the disease, such as and young parents also express a need for accompaniment in their administrative and financial steps they have to take and proceed. And to start these is seen as too demanding for the young parents who want to maximize the time with their family and their children. The literature is lacking in terms of data for one-parent families. In one of the studies we saw, one of the participants was forced to go back to live with her mother, with her child, and was no longer able to pay the rent given the costs associated with the disease. But few studies have focused on the situation of one-parent families. So young adults and young children one of the features of this is that some will start palliative care to remain as long as possible by their family, but they will be haunted by feelings of guilt for no longer be able to play a role as a parent or a spouse. So it'd be relevant for future research to echo the feelings of the young parents, the children, and the grandparents, to have a deeper understanding of the reality of families, a parent of which is suffering from cancer. On the other hand, what also fed our thought had to do with caregivers. There were the debris works by debris which focus on the caregivers accompanying young families, a parent of which is suffering from severe cancer. There's on one title, in a title, caregiver says it's tougher. So when he speaks with adolescents and young adults, compared with his other Um, it's tougher for the caregivers, but it also echoes what we have seen. That is that is how uncomfortable it is to address the family when it's young adults. Why? Because one is then in a phase where the will to live is very strong, and for them it is unacceptable. So the feeling of not having a choice, this is also felt by the caregivers, and this will taint the way they will communicate it. So we'll wait longer before mentioning palliative care, and also the tragic character of the follow-up. In other words, there's an emotional involvement. So the, the emotional involvement is greater because often they are the same age as the patient. So this will affect the way I will speak of treatments. You know, if I speak to someone who could be myself or my sister, whereas you're dealing with someone older. So this will, in a way, affect the way we will bring about the treatments. And there's also a reluctance to involve parents and spouses who hope a lot in the treatment. On the other hand, there's the lack of time to accompany these parents and their spouses. And since time is short, we prefer to limit our interventions because it is too draining emotionally and it requires too much time. In the light of all these findings, it fed our project, our research project. We spoke a bit to the new Centre de Recherche en Oncologie in Quebec City and also to the coordinator of the Bon Enfant Center to know what they thought about the project. They fought it capital because they felt it, the distress of their caregivers and of the young parents who could not. So they've accepted to cooperate to this fine project, and the purpose of it is to document the psychosocial experience of young parents, but also that of co-parents, the spouse or former spouse, the children, and the significant others through the trajectory of advanced sickness, because there are also parents who are preparing themselves to lose a child. So we wanted to document their own experience. As parent or grandparent, they are affected by this, and for young parents, there's a lot of friends who are also involved in the accompaniment and the follow-up, and there is little literature on what they experience, but they also afford an important support. So in order to be able to dovetail all of this is one of our purposes. So we would like to develop methods and to describe the experience of the young parents and their entourage through different steps of the evolution. So we will meet them several times and to assess their needs. Then we will document the reality and the psychosocial needs of the immediate surroundings of the young parents. And during the first weeks that will follow the death, and to communicate this knowledge through workshops where caregivers will be able to gather, and young parents and members of the entourage who are experiencing this. So target population are young parents with cancer, advanced cancer. We've decided to aim for the 50 years and younger. I mean, there are adults who are 47, but who match these criteria. That's why they decided to place the age limit at the 40s. And So, so those who are affected by cancer will be able to tell us what are the significant people that should be included in this study, and also the caregivers that accompany them. We're speaking nurses, social workers, and physicians and oncologists. Here is the data collected. So we started the first wave, it's ongoing, and the second wave is in a few days. Then at the end of winter, we'll begin the semi-directed individual interviews. 8 patients with 2 members of their surrounding, which gives 24. And third wave, we are going back to the Chipaka, the members of their surroundings. We might lose Marta and Chipaka.
Moment-là, les membres de leur entourage.
We see the members of their entourage, and so we will see the workshops that are planned. And what we're waiting for as a result is to be able to document this reality that the people are living in of advanced cancer, and training the need or the offering the tools necessary to the population, giving small videos, talk about the subject in school, and ameliorate the offer that is given in palliative care. And so that's it. And so thank you for listening. Ok, non, je vais faire 30 minutes. Je vais finir la fin, je vais finir. Any questions? Comments? We have maybe we be able to take one question. I don't have any online, so well, thank you guys. Thank you, Gabrielle and Elizabeth. And not Elizabeth as within the program. And so without waiting anymore, we will go to the next presentation, the student presentations for this section. And so we have 3 other students. We will start with, we will invite Marta to start off. Martisella is a student in the under the supervision of Marianne, and she's going to talk about the challenges of psychiatric and pediatric challenges. So thank you, Francois, and everybody that are still here. I hope that will be dynamic enough for my presentation. So I am on the supervision of Marianne Boutier, and for my PhD, I work with the Espoir team, and so that's what we were talking about this morning in this plénière, and we're working in collaboration with them, and I will present the preliminary results, and I'm declaring that I don't have any BMO affiliation. And so I hope at the end of this presentation you'll be able to understand the palliative challenges in the palliative care domain, and to know the ethical challenges of the professional people that work in this context, and also knowing the importance of palliative care. And so here are the few competence that CanMed will use. So we will start with the context. Who is the Espoir team? And so this team is a consultant team that was created in '99. It's a specialized team that was made in '99, and actually it has 2 nurses and also a pediatrician. So there are a few people that are been added to the team, and so this team is developing a setting of research, and that's where my research is based on. So if we look into the literature, we see that in pediatric research, um, that it that it is, or during the professionals or the parents, we see that there's articles where they're looking for the opinions of the parents, and that's what comes out of it. And so it's really important for for Team Espoir, and they see more and more challenges through time, and so they're trying to see what are the challenges that we meet up. And so the challenges that we have, the ethical challenges we have, in the palliative, adult palliative care, we see that it's here to help the work of the people that work in adult palliative care. And so, my question is, what are the ethical and the practices? So my project is based on the paradigm of the ethical research and the setting of three approaches analytic, and so that saw the day at the end the humanitarian challenges that we saw in the healthcare system. And so don't be scared, this is a project that is based off 3 studies. And so with the talking about the pediatric palliative care at the Cedric Hospital, and the amelioration of the practices or improvement of those practices. And so I don't think I'll be able to go through the 2 studies like I wanted to. So I will present the first study. So for the first studies, there's 2 sections. The first study, we're trying to contextualize the interviews. More importantly, this first, so you will be able to see the theme of the cases that follow. So for the first section, we created a database that was followed all the teams from 2000 to 2020, where we can see the date of consultation of the number of cases that were followed, the age of the child, and many other factors. And we made this analysis with SPFS, and so I'm going to present the results. So if you see this graph, it tells us the amount of consultation that they had from 2000 to 2020. And so these are all the first consultation that we made. So for the interventions of the team, we can see it being separated by context and disciplines, domains. And of all the followed case of the children, NTR is the survival, and the age of survival is the age of the children varies. It goes up to 24-year-old, and we see that half of the cases are linked to conditions where there's a cure offered to them, but the palliative care are still there to offer help in case of uncertainty. And so it's important to keep in mind. And it was put forward by Team Espoir. So I will now present the second section. So we made these interviews virtually, and we explored different thematics or subjects or teams. And so we asked them to explain their stories and the challenges that they saw in their practices, and what brought them to come to work in palliative care of pediatric palliative care. And so there were people in Team Espoir, but also the people that work in collaboration with them. And so we talk about how do we see the future of the palliative care, pediatric palliative care. And so these interviews lasted from 45 minutes to an hour and 30. And as you can see here, there was 2 groups. So the first one was a pool of the base pool. And so the sample group. And so we transcribed these interviews, and then we made them in a thematics graph. So here you can see the 24 portraits of the 24 participants. So these are the categories: the doctors, managers, counselors, and other things. So these participants came from the different sectors. I don't know if it changed. So here you can see the different sectors. You can see the bigger N because some participant can be in many fields at the same time, and so that's why there's more than 24 people or 24 numbers in this graph. And so the idea was not to stay in the hospital, but also see go towards the organization or management side of the pediatric palliative care. And so that's what we did. And so now we come inside in the main part of the subject. And so the result we have put out or put a highlight on 4 interdependent aspects. We can see that there's a categorization. There's a societal, or we have to the death in the future came out a lot, and to thinking about that between the autonomy of the people and the protection of the vulnerable people. And so here you can read the challenges, the technical challenges that we can see. And so the problem that we see is that the interdisciplinary work that we had to do, but these work also came with some challenges. I'm going to pass to the next slide because I see the time going on fast. And here are some few considerations that you can keep in mind. These are the values that guide our professional worker in their decision making in their works. That is very important to them to always come back to this collaboration and area. And so I'm going to close with this. I wanted to show you a few results of the second studies, but I will go to the conclusion. So I will leave you with this conclusion where it reflects the result that we had. And I think the where we will go to the child and his family. And so it's really important to integrate palliative care into the reflection, and we have to involve all the tools to make the right decision and to support the people that work in this field, in those fields. Thank you, Marta. Thank you for respecting our times. It's perfect. The next conference worker is going to be Jessica Boivin, who is here doing a master's with Dr. Bruno Gagnon, that is working in the Faculty of Health of Laval. It's going to be different in this conference, but it's going to change the ambience that we usually have. And so it's about the refinement of the psychomotor skills in the patients. And so hi everybody. To the advanced cancer stages that suffer from delirium, that work in health worker. So since we've been made the title, so before we start, I don't have any affiliation to any BMOs or non-BMOs. And so in the DM5, the slowness of the psychomotor skills are related to lowerness of psychomotor skills and our ability to think. And so some people are not close to delirium, but okay. So actually, there are many tools that include cognitive items and motor skills, and so actually they're involved in of a unidimensional that is based on componentable time, and they only bring a general idea of the state of the patient. So of the known and used one, we find the nursing delirium screening scale and the memorial delirium assessment scales. And so these two tools are based on the base that goes from 0 to 2, and the MDAS from 0 to 3 to 0 to none to extremely severe. And so these datas are not here to evaluate properly the it means that their quality of life is affected by this. Slowing down of the psychomotor skills with advanced cancers that don't suffer from delirium. And so to think about this, we brought four discussion groups with different type of health workers in oncology, and it had different type of external clinicals and external groups. And so we made a new group of, and these are the terms that we had, were perception, evaluation, and taking charge the psychomotor skills. And so it was here to make the experience come out, which is important in the phenomenological approach. We used a thematic analysis, iterative codification, and a double codage. And a team of the research coded 10% of the transcription. And so we had a total of 19 participants, which the age is of 42 years old, and most of it is of females or feminine sex, which is 70%. And there was a lot of different professions, and what we found is that most of our participants were nurses, and male nurses and female nurses, and a lot of them worked a lot in oncology. And so we worked a lot with people with less than 5 years of experience. And so cognitive and physical, and we can see it in different stations in here, like the analysis, the person is less mentally active and has a lot of forgetful state of mind. And so there are a lot of examples where our patients walk less faster than usually, or it's slower to remove their coat, or when they're sitting down in the desk or the office of the doctor, and what they saw is that it's really a generalized slowness in all the tasks that the patient does. And so the professional also said that there was a slowing down in the presence of the psychomotor skills. And so she said that it was something that is that evolves. It's something that gets worse day by day, and it was also it was more evident when it was more noticeable in cases where they were with a patient on a day-to-day basis, because they could see the progress. And so the professionals also talked about the perception of the roles. The doctor said, is it something really that has to be rectified, or considered as a problem, but there was also a nursing that said that's part of the palliative care process. And so another doctor also went the same way as the nurse. And so the idea of the existential distress that the patient might have that is linked to slowing down of the psychomotor skill is something that we can see in the patients, because they might have a grief. There's a grief because they have a grief of being able to find back their physical health. And so when it gets solidified in their mind, it affects more and more their physical state. And so we talked a lot of the process of the slowing down of the psychomotor skills, and of these conversations there was a lot of ideas that came out of this, where we could see that depression and the medical hardships were there. And so they talked about actual interventions where they said that they had to repeat, or they said that the how there was a doctor that added that the slowing down of the psychomotor skill that is isolated, is there was a chance of prescribing medication to help that. And so they said that switching from opium to opioids to metiacid medication could help to have a better cognitive skills. And so there was also a doctor that said that it was really important to have the profession said that there was a lot of suggestion of how to support the slowing down of psychomotor skills. And so they should make more followings with their patients to see how it goes. And so it should be a skill or a tool that is more accessible to the file of the patients. And this tool could be there to help the future colleagues to adapt their interventions with this data. And so and so like this nurse said, even though there was a beautiful team, there's still a lack of resources, and the help takes a lot of time. And so the delay to support the patient and really is not good for the quality of life of these patients. And so to conclude, these professionals takes time to realize the importance of the dynastic of that came in a lot of the discussion that we had. And it was also a need that there was a need for a tool to better help with the psychomotor skills slowness. And so, and also the existential crisis that the patients might have. And the only thing that came out is that the people don't feel tooled enough to take care of the people that suffer from psychomotor skills slowdown. And so thank you for listening. Thank you, Jessica. We will go to the last presentation of the day. She went over for 5 minutes, but I think it's important that every students get a voice. And so we're gonna listen to Malek Amiri, who is a PhD student who studies in the University of Laval. And so we will talk about the analytical existential of Martin Heidegger, of the psychology of the anxiety of the people that are suffering from it, and end of that life problem. And so my presentation is going to be different, because where it's going to talk about a different part of my PhD, where it's going to talk about the anxiety or the people that will be that have a cancer at the end of their life. And so my project is under the direction of Nicolas Monarch, and declaring that I have no conflict of interest. And just as my principal objective of learning, it would be the understanding of and applying the, and I will explain later the terms that are proposed by Marta and Edgar. In general, for a long time, people or the the people that come close to death is a path that everybody will take, and so the living the a life close to death is a drama filled state of life, and it can bring a lot of anxiety. And so it's a hard emotion to have, and it's also a complex emotion, but it has of ontologic practices. The difference of all the studies of the scientific literature rests on the approaches of quantitative data, and so it's a positive paradigm. And so I took the option a more innovative approach, which is a conception of Martin Heidegger, which is a German philosopher. And so the goal is to explore the way Martin Heidegger wanted to see of the people that had cancer at the end of life, which is an experience that can be lived in an authentic way or in an inauthentic way. And so in my project, I will talk about the main work of Marta Heidegger, which was published in 1927, to talk about the dynamic of the different experience of this experience, the human experience. And so it's here to dissect the experience of the person that is affected by cancer. And so the authentic possibility goes to the acceptation of dying, but talks about how they're scared of the unknown and the pain that will come, and the people that will have to live without them being alive. But the authentic responsibility is a reaction of all this fear and a fact to run away from these fears. And so these existential crises, in the existential crisis, he uses it to design the authentic and inauthentic people that are affected by cancer, which is a choice of life to install and do this thing. But Martin Heidegger goes and to talk about the existential who conditions the people that are affected by cancer, where it authorizes the existential and existential state. And so our way of understanding death is as a existential structure which authorizes the existence of the existentials. So the way of understanding death in an authentic way and in an authentic way. And so more concretely, we're waiting or expecting that the anxiety before death or under death are separated in two separate ways. And so each of them, of these two models, we have the report the link to death appears in three dimensions. We have the first dimension, which is it's to on understanding, which is the first way of understanding it, and then there's the affective or emotional way of reacting to it, which is being scared of the death, and then the there's the talking about death all the time isn't a way of talking about this. And there's the people that is reduced to one case where there's an event who produces itself on a daily basis in a banal way in the states in extending. It's always the fear that predominates where this manifestation can disengagement of about its own death. And so because of the effects of the two first points or dimension of the authentic and inauthentic approaches, the people on the day-to-day basis or will die from the current personal aspect. And so in this case we'll say we will die one day, but for now I will stay sound and safe while I'm alive. And so we see that it's nobody. At the end we will see that there's two authentic model. There's a understanding authentic there's a authentic understanding affection understanding and a talkative authentic talkativeness. And so the people can confirm its own death in all dimension and characteristics. And so it's non-relational. The death is always lived in a way that's isolated from other people. And so the operation of anxiety that determines the patient accesses and pushing himself close to his own death. And so for Marta and Edgar, he says that the daily talkativeness is not existential in the authentic way of the state of being. And so in that level it says that the silence is the guardian of the daily talkativeness. And so as last point, we always expect that will be a transition from one state to another state, from an authentic state to an inauthentic state. And so the person it will always change the back and forth between these two ways of being. And so from this discussion, the study of the anxiety of die brings a lot of. So as the first point, we have to comfort. We have to not take in consideration the state of consideration of the dominant part. So of the truth and construction thinking, we have to make appear the human side of the people. And thirdly, we have to put under parentheses the existence of and take into consideration everything that is database. And to fourthly and finally, we have to emerge the
Et même pour la clinique aussi, il faudrait encourager les occasions de dialogue entre les patients qui éprouvent l'angoisse devant la mort et le personnel de santé, mais aussi entre les chercheurs et les praticiens. Il faudrait aussi encourager et promouvoir la formation initiale et continue sur l'expérience de l'angoisse devant la mort. Pour conclure, l'expérience de l'angoisse devant la mort reste un phénomène humain complexe et multidimensionnel et très difficile aussi. Et c'est pour cette raison, pour le comprendre encore plus, c'est important de prendre en considération 4 dimensions essentielles que j'aborde aussi dans mon projet de doctorat. C'est la corporeité, et non pas juste la corporalité, donc le corps vécu, mais aussi le corps objectif. La corporeité, la relationnalité, la temporalité et la spatialité. Et pour comprendre aussi, ou pour aborder cette expérience, il faudrait prendre en considération des théories, des conceptions qui découlent de la discipline infirmière, mais aussi il faut rester ouvert sur d'autres disciplines comme la philosophie ou la psychologie. Et comme un petit point de réflexion, à la lumière de la conception de Martin Heidegger, je me demande, ou peut-être on peut même se demander si parfois les demandes ou une demande d'aide médicale à mourir ne résulte pas d'un rapport inauthentique à la mort chez des personnes atteintes de cancer. Et merci.
Merci, Malek. Donc, ça conclut notre journée thématique. Merci, on a un petit peu de retard. Je vous remercie d'avoir resté jusqu'à la fin. Et comme je l'ai présenté ce matin, on a une demi-journée scientifique qui s'en vient le 3 février prochain avec nos collègues français. Et ça va être gratuit, ça va être en ligne. Vous allez être interpellés à participer, vous inscrire. Et ça va être sur tout ce qui s'appelle l'accessibilité pour les minorités visibles, pour tous en fait. Et voilà. Ceci étant dit, je vous remercie infiniment pour votre présence et je vous dis à la prochaine. Suivez-nous puis encouragez-nous sur les médias sociaux. Ça va nous faire plaisir de vous rencontrer. Merci.